Okay, I'm going to try to do just kind of a quick little review on some of our exemplars to help you guys separate them out a little bit. I will also post the PowerPoints themselves, but definitely make sure that you're listening to it and not just going through the PowerPoints, okay? Pass it on to your buddies. Okay, so we're going to start out with a mom. We're going to talk about Layla. And you guys remember her from when we did our case study review before. So we're going to repeat her a little bit, and there's a reason. Layla is a 19-year-old G2P1 at 40 and 1 with a history of asthma. She is O positive. She is in the end of her second day of an induction of labor for diet-controlled GDM. Layla delivers a beautiful 8-pound, 14-ounce baby boy after a 2-minute shoulder dystocia. He is taken to the warmer for evaluation and neonatal resuscitation. The nurse starts an initial potassium bolus. When she asks the provider if they want the second bolus, the provider states that they do need the second bolus. The placenta is delivered 2 minutes after a son, and a second-degree laceration is repaired. If you guys remember from our previous one, Layla is our one. She has shoulder dystocia, and she ends up having a postpartum hemorrhage. We're not going to get into her postpartum hemorrhage right now. We're going to talk a little bit more about her afterwards, and then also about her son. On Layla's second day postpartum, Layla's vitals are as follows. Heart rate 124, respirators 24, blood pressure 88/58. Previously, she was 120/80. Layla reports she's feeling dizzy and lightheaded when she stands up, and that her heart feels like it's racing. Labs are reviewed, and Layla's CVC comes back as hemoglobin of 7 and hematocrit of 21. The provider orders a transfusion for Layla due to experiencing signs and symptoms of anemia. The nurse monitors for signs of a transfusion reaction, such as fever, chest pain, shortness of breath, and chills. If the nurse saw any of these signs of a transfusion reaction, what would the nurse do? The first thing the nurse would always do is stop the transfusion. Okay, that's always the first thing they do is stop the transfusion. If we decided that there was a transfusion reaction, you would make sure you took the blood down and the tube that the blood was running through, and you would send all of that back to the lab for investigation. Okay. So looking back at the signs and symptoms of anemia, feeling weak or tired, shortness of breath. For her, we also had the tachycardia. That's a big sign. It's not listed on these little pictures, but I kind of like the pictures, you know. And it also has the pica on the pictures. You know, that's always a good thing to remember as well. But feeling cold and that shortness of breath. Well, for us, though, in that clinical setting, we're going to see the tachycardia first and that dizzy, lightheaded first, okay? Okay. At delivery, Layla's son, Ty, is taken to the warmer for evaluation. His initial APGARs are 2 for pulse, 0 for respiration, 0 for activity, 0 for appearance, 0 for grimace. Positive pressure ventilation is started. By the 5-minute APGAR, Ty is 8, 1 for appearance, 2 for pulse, 2 for grimace, 1 for activity, 2 for respirations. Signs of respiratory distress are noted. So what do we see with respiratory distress? Well, we see nasal flaring, grunting, and retractions, right? Those are the 3 big ones. But also remember, if you see things like cyanosis, central cyanosis is never a good thing. Cyanosis, if you want to kind of put that in your head, is never a good thing. Acrocyanosis, you guys have heard me say, yes, that's a normal finding. And it is a normal finding, but don't make yourself ignore the other cyanosis. Tachypnea, never a good thing, okay? So our classic signs of respiratory distress are the nasal flaring, retractions, and grunting. But it doesn't make us forget that cyanosis, being blue, is never good, right? Being blue is never good. And that tachypnea would not be good either. Just like an adult. If I'm suddenly breathing like 30 and you guys aren't doing anything for me, I'm going to be a little upset at you. Be honest. Okay, so next piece, initial blood glucose is 38. Why do they take it? Well, remember, Layla was a gestational diabetic. That's why I included the first part of her story. She was a gestational diabetic. So that's why we took her blood sugar, okay? What are the signs and symptoms that you see with low blood sugar? Well, jitteriness, you remember? So the Maro reflex. the Mara reflex is our normal startle reflex. That's this one, right? And when they do it, they do almost like a C shape with their hand when they're doing the Mara reflex. You've seen it in the clinical setting. It's like this, right? Totally normal. That's normal. Startle reflex is normal. That's good. Mara reflex is normal. When they do an overactive one, when that's not normal. I just knocked over my drink, but I'm going to ignore it. Anyways, that's not normal, okay? So if that happens, that would be a sign of hypoglycemia. Other things you can see, grunting, irritability, so they have respiratory distress. You see hypothermia. Remember, hypothermia and hypoglycemia are heavily connected. It's still my drink. Are heavily connected, okay? So we would definitely want to know what their blood sugar is and want to know what their temperature is. Those are two very connected things. Okay, so we give 15 mLs of donor breast milk. Good deal. Ty's temperature is taken, and it's known to be 96.8. Repeat blood sugar is 30. What are some of the reasons his blood sugar may have dropped? Well, if he is cold, his blood sugar is not going to come up. So now we have to make sure we're warming him up and fixing that blood sugar. So he's put on hypothermia protocol and given a repeat feeding of donor breast milk. His repeat blood sugar is 45. So it's on its way up. 45 we're okay with, but it's really on the line. So we're watching it, okay? So we don't want it to get any lower than that. Ty's temperature is taken. He's 98.6. Cool, good deal. Good thing for Ty. Ty was successfully weaned off of his O2. Hypothermia protocol was successful. Now Ty's DAT status has come back. His Coombs test has come back positive. Ooh, okay. So 6 hours after his delivery, they drew a CBC and a serum bilirubin. What's another way that they could have tested that bilirubin? Remember, they could have also done the transcutaneous one, right, through the skin. Okay, well, his first bilirubin was 6. However, Ty's nurse noticed that Ty appeared jaundiced at his 24-hour screen. She was already going to draw it, but now she's like, ooh, I'm a little worried about it. What would some other things that you would see with jaundice, with hyperbilirubinemia? So you'd also see significant lethargy and poor feeding, okay? She repeats the serum bilirubin and notes that it's 14. Ty was started on phototherapy. What are some of the reasons for this? Well, so Ty was, first of all, with his mom being O positive, and they drew that DAT, this would be considered pathologic jaundice, right? Pathologic jaundice is when we have the ABO incompatibilities. If you want to just put that in your head, is one of the main reasons, one of the most common reasons, one of the reasons that you probably see on like NCLEX questions. That will help you, okay? Physiologic jaundice, that's the one where it has to do with poor intake, okay? Poor intake where we see an increased incidence when they're breastfeeding because of the fact that they sometimes have poor intake with breastfeeding. There's a lot of things that go into breastfeeding. There's latch, there's supply issues. So all of that really plays a part in breastfeeding. So with our pathologic jaundice, it has really kind of nothing to do with it. It really has to do with those ABO incompatibilities, okay? So that's the reason why he's got the jaundice right now, this pathologic jaundice. So what do we do when we put them under phototherapy? Well, I think I have a little pointer here, and I think you guys might be able to see it. Let me see. Let me turn on my laser pointer. So we turn on, this is our bank light, our phototherapy light. We have them on a fiber optic bed or a blanket is what we can use for underneath him. We make sure that his eyes are closed, and then we put on that mask on top of his eyes to protect his eyes from retinal damage, okay? We would want to change his position. Just like an adult, he can get pressure sores too. So we'd want to change his position about every 2 to 3 hours. We would still encourage feeding and still encourage breastfeeding. That's a myth to think that just because they're going under phototherapy that all of a sudden they can't breastfeed anymore. Okay, we'd still encourage breastfeeding. Okay, so we'd want to watch him until his bilirubin levels start to drop. Okay, well, his bilirubin levels have dropped to 8 after 24 hours of phototherapy, and the provider is good with this because at this point in time, he's close to 48 hours old. So 8 at 48 hours old, he's good. Okay. We might watch him. We might do a rebound bilirubin. And you guys remember from the Jeopardy, we would always do a serum once they started on phototherapy, not a TCB. I really don't feel like NCLEX is going to get in that kind of detail, but it's still a fun thing to know, especially if clinical practice comes into play. So they are able to go home. Good deal. Let's see what happens with them though. Layla and Ty go to Ty's 6-month appointment. Layla reports that she's been crying all the time, has no support at home, and is really struggling with Ty. She states that Ty is just a fussy baby. She's asking, is there anything I can do about this? Well, the nurse tells her, sometimes their personalities, they're already there. Just because he feels like a fussy baby, there's nothing that you're doing to cause the fussiness. That's part of his personality, and we're going to figure out what his little personality is going to be. Maybe he's a feisty one. You never know. So she's trying to, the nurse trying to talk to Layla about this, and they're suspecting that she's dealing with some postpartum depression. The provider's talking to Layla about different options. So of course the provider's going to say, SSRIs if you're still breastfeeding, they're compatible with breast milk. If we had to do the brexanolone, it's got some really, brexanolone, it's got some really, really good evidence-based evidence that, FDA has approved it for postpartum depression, but you would have to be admitted for 60 hours for a continuous infusion. You'd have to be on a pulse ox the whole entire time, and it's not, you would not be able to breastfeed during it, but it's okay. We'd hook you up to a breast pump, and you'd be able to keep up your lactation that way. So you could still pump. We just wouldn't want him to be breastfeeding while you're actively on the medication, that's all. So Layla decides, I'm going to do an SSRI. I don't have, maybe she doesn't have the financial means at the time to pay for her part of being admitted. So she says, okay, I'm going to do this SSRI. Well, let's see how Ty's doing, because that's a lot for his mom to be going through. It sounds like she doesn't have any support. So during Ty's appointment, he's found to have dropped drastically in weight categories. The provider's concerned that he's at risk for failure to thrive. What weight category is considered failure to thrive, according to Perry? So remember, it's between 3 to 5%. Well, Ty's weight is now at 10%. But remember, Ty was a really big baby. So the provider says, well, he's not really failure to thrive yet, but we want to watch him. We're a little concerned that he's dropped in weight so much. So let's see what we can do. Now that you're on these SSRIs, let's see if we can help get you some more support and see if that helps with his weight. Maybe now that he's 6 months old, he can actually start to eat solid foods. And so, now that we can start introducing some solid foods in addition to breastfeeding or in addition to formula, this is that point, then maybe we can go ahead and see if that helps him gain weight. Ty's cousin. Okay, Keith is Ty's cousin. He was born with features of small ears. He is microcephalic, smooth phalangium, thin upper lip. So what are we thinking of? Fetal alcohol syndrome. I should have put a picture of that too. I didn't. I put the next part. But that's fetal alcohol syndrome, right? So Keith his mother was admitted for significant alcohol use in pregnancy and opioid use. Okay, that's why we have that needle abstinence syndrome picture, right? Well, Keith was seen with excessive sucking, poor feeding, high-pitched cry, and nasal stuffiness. What's causing these signs? We know it's withdrawal. So what do we need to do? We need to put him on morphine. There's morphine. There's benzodiazepines that we might consider. Some facilities will just still do methadone. They might do clonidine. So kind of the same medications that you want to think about for adults. Those are some of the same things that you're considering for babies too. Keith is a withdrawn infant. He shows little interest in the environment around him. And there's our fetal alcohol syndrome Keith, right? So indistinct philtrum. I was saying it wrong the whole time, guys. I'm so sorry. Philtrum, indistinct philtrum. Thin upper lip, small eye opening, small ears, smaller head, microcephalic. While Keith is withdrawn, he shows little interest in the environment around him. Keith has not started babbling. He's 11 months. That's unusual. Remember, they should be making at least syllables by that point. Keith did not have head control until 6 months. That's also unusual. It should have happened at least by 4 months. In 11 months, he still cannot sit without full support. So these are some concerns for Keith. You know, it's starting to look like the fetal alcohol syndrome. He's starting to have some developmental and possibly cognitive delays from this. So we're going to be watching him. Okay, just a little reminder about late preterm infants. You know, they're between 34 and 36 and 6. We consider them late preterm rather than near term. We don't use that term anymore. We say, you know, they have a higher risk for problems like thermoregulation, issues with hypoglycemia, hyperbilirubinemia, sepsis, and respiratory function. Okay, let's talk about Nadia. Nadia was born at 34 weeks. Nadia has been a poor feeder since day 1. She's currently a week old and on gavage feedings or chimney feeds of formula in the NICU. Nadia's nurse finds her with a shiny, distended abdomen, bloody stools, and temperature instability. What does Nadia's nurse suspect? Well, Nadia's nurse suspects necrotizing enterocolitis, right? Those are some of the classic signs of necrotizing enterocolitis. What is a protective factor against NEC for Nadia? So remember, breast milk is a protective factor. So if you're looking at different babies that are taking in formula and breast milk is a protective factor versus formula. Okay. We're switching. Sorry, guys. We're switching to something else. So Nadia's sister, Natasha, is born with a scaphoid abdomen, dyspnea, and one side of the chest is larger. What diagnosis does Nadia's nurse suspect? What do you guys think? If you're thinking diaphragmatic hernia, you would be right. Diaphragmatic hernia. So this is one of the issues that, because of the fact we may not always be able to diagnose it before in utero, we might have seen it, but we may not have. If we have this issue where you have the bowels herniating through the diaphragm, you can see it right here. I'm going to use my little pointer. Through the diaphragm, bowels are up here on the left side of the chest. So this left side of the chest is going to be all, it's going to come out, right? They're going to have that sunken in, or scaphoid abdomen means the same thing, guys, sunken in, right? They're going to have dyspnea. I mean, you can just see how this baby has dyspnea. So this needs surgical intervention, okay? Let's talk about Jessie. Jesse's born Jesse's born at 8 a.m. The nurse is doing his first newborn assessment and notices excessive salivation. Jesse's mom reports that Jesse did not latch well, and she thought he was choking during the feed. What does the nurse suspect? If you are thinking esophageal atresia or tracheoesophageal fistula, you would be correct. Let's look at it. Okay. So we see our normal esophagus right here in our normal trachea. This is our esophagus. This is our trachea. Okay, so trachea is where, of course, is basically our airway, and our esophagus is where it goes to our stomach. So where we have an esophageal atresia, you can see it right here where our esophagus cuts off. Okay, so our esophagus does not go all the way down to our stomach like it's supposed to. An esophageal fistula, you have the atresia and then the fistula where it crosses into the trachea. So you can see how this could really cause some issues. So what do you see with the babies? Excessive salivation is one of the big things, and also regurgitation, vomiting after feeding, choking, coughing, that kind of thing. You can see why they'd be coughing. Okay, Jessie has surgery to repair esophageal atresia. Boom, we got it. After several weeks in the NICU, he is discharged. Jesse's mom has been pumping while he was in the nursery. She followed good hand hygiene while pumping because babies in the nursery, we really want to watch out for infection, or in the NICU, we really want to watch out for infection. Jesse's mom asks how best she can tell that Jesse's getting enough. What does the nurse tell her? So do you guys remember how many diapers they're supposed to have? So these guys got to have between 6 to 8 wet diapers. Okay, every day. That's what they got to have. Okay, so that's what the nurse is going to tell her. 6 to 8 wet diapers every day. That's one of the best ways you can tell. Okay, so Kai was born via C-section. Kai had a known myomeningocele because of his level 2 fetal anomaly ultrasound at 20 weeks, and had a known elevated maternal serum alpha fetal protein. Okay, what care does the nurse provide Kai? So Kai has, myomeningocele. He needs to be prone on his belly. He needs to have his head turned to the side, and they're going to do nipple feeds. Remember, we talked about that. Kai is going to need surgery. One of the things that I just wanted to bring up with Kai, so we had talked in class about the latex allergy in my AM class, actually, and I said, I don't know why it's on the above slide. So there's not a connection with the defect specifically in latex allergy. It's more that the theory is that it's the exposure. So they do have a higher incidence. Children that are born with spina bifida specifically do have a higher incidence of latex allergies. The theory is that because of the continual exposure to latex throughout their life, that's maybe the reason why they develop that allergy later. So the book didn't have a statistic. In my PM class, we were able to find that it was like greater than 50%, I think 60% of kids ended up with a latex allergy later in life. So that definitely kind of summed it up for us about why that was on there. Okay, that is the majority of this review. I hope, it kind of packaged things up in like a little short 24-minute review for you guys. If there's anything else that you want me to review, give me a heads up. I probably won't be able to do it until Monday morning, but let me know and I will try to do another recording. Okay, thank you. Bye.